Good afternoon and welcome to today's webinar, Complications and Adverse Events in Varicose Vein Treatment. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and the Society for Clinical Vascular Surgery. And now I would like to introduce today's guest speaker, Dr. Ellen Dillavou. Dr. Dillavou is the Director of Vascular Surgery at the Duke Regional Hospital in Durham, North Carolina, and Associate Professor of Surgery for the Duke University Health System. She serves on the IAC Vein Center Board of Directors representing SCVS. She is a faculty member for the American Venous Forum and is past chairperson of the AVF Fellows Education course. She is a distinguished fellow of the Society of Vascular Surgery. Dr. Dillavou is a published author whose work is found in many respected journals, such as the Annals of Vascular Surgery, the Journal of Vascular Surgery, and the Journal of Cardiovascular Surgery. She is a true expert in the field of vascular surgery disorders and specializes in vein disease and vascular access, and we are happy to have her with us today. With that said, I will now turn the webinar over to today's speaker, Dr. Ellen Dillavou. Doctor?
Thank you, Kelly. I appreciate the IAC inviting me to participate in this webinar, and I appreciate all of our viewers and listeners who have logged in for today's session. Today, the objectives of this session include description of the most common complications encountered in the treatment of superficial varicose veins. We are also going to outline how reporting of these complications can work with electronic medical records or a hand log to facilitate patient safety. We would like to illustrate how the QA process of reviews uses complication logs to make facility improvements and to improve patient results, satisfaction, and safety. Finally, we will discuss how the IAC accreditation facilitates the above processes and improves patient care. Superficial venous treatment is one of the most commonly performed procedures in the U.S. today. The common modalities of treatment include thermal ablation, non-thermal ablation, foam sclerotherapy, visual sclerotherapy, and phlebectomy. Today, in this webinar, we'll be discussing these common complications of commonly performed procedures. We will talk about the need for reporting complications, the methods of reporting complications, and how these are a very important part of quality improvement. Thermal ablation. This was introduced in the early 1990s and is perhaps the most common method of saphenous ablation in the U.S. It can be performed by radiofrequency or laser, and due to the similarities of these techniques, I'll be discussing these together. During the procedure of thermal ablation, we perform this for symptomatic reflux of more than 5 0.5 seconds, in great, small, or anterior saphenous veins. To perform this procedure, a catheter is inserted in a distal vein and positioned 3 to 5 centimeters from the deep venous junction. These techniques can also be used to ablate perforating veins, which are more than 3.5 millimeters with greater than 0.5 seconds of reflux in CAP 5 and 6 patients. After the catheter is positioned properly in the vein to be treated, we can then tumesce around the vein to be treated to both create a insulating envelope to absorb heat from the treatment, to anesthetize the patient, and to protect surrounding structures. The tumescence also decreases the venous diameter and makes the procedure more effective. After the tumescence is installed and the patient is comfortable, the vein is then heated to induce vein injury and eventual closure. In most practices, an ultrasound is done between 2 and 14 days after the procedure to make sure that the treated vein has been closed and make sure that no complications have been logged. No complications have happened. The first complication that I want to talk about is endothermal heat-induced thrombosis, or EHIT. And this is a complication that was described after thermal ablation was initiated. This is a new complication that really only pertains to thermal ablation and now is actually used to talk about thermal and non-thermal ablation, although technically it can only happen with thermal ablation, as the name suggests. What this is thrombus that extends from the treated vein into deep veins. It was originally described by Dr. Kabnick and his colleagues from the great saphenous vein extending into the common femoral vein. It is divided into 4 categories, and these categories directly correlate with the treatments as well as the outcome of these complications. Class 1 EHIT is when thrombus extends to the junction between the saphenous and the common femoral vein. Class 2 is when there's thrombus that extends into the deep vein with less than 50% cross-sectional diameter. This is also commonly referred to as a tongue of thrombus. Class 3 is when you have that tongue of thrombus extending into the deep veins with more than 50% cross-sectional diameter of the deep vein being taken up by thrombus. Class 4 EHIT is when you have complete deep venous occlusion from the treated vein into the deep vein. When we report EHIT, many groups commonly group Class 1 and 2 and Class 3 and 4 together. Class 1 and 2 are categorized together as they may be treated with aspirin, observations, and repeat scanning to make sure that the patient does not worsen. Class 3 and 4 EHIT really mandate anticoagulation until the thrombus resolves or until 3 months have passed, whichever seems most clinically appropriate. There can also be DVT associated with non-thermal ablation or thermal ablation that is not due to EHIT, but is in fact due to distal extension of thrombus into the deep veins. This is slightly different than EHIT, but usually requires anticoagulation. It's important for groups to keep track of their EHIT and DVT rates, as these should be less than 5% of all ablations performed. Another common complication and outcome that needs to be recorded after ablations is closure of the vein. Closure rates need to be reported because recurrent symptoms have been linked to closure failures. Also, it is important that a group knows their closure rates to make sure that they are performing the procedures in order to be effective to our patients. When reporting closure rates, the IAC has suggested that these be broken down into patients with no closure, less than 50% closure, 50 to 80% closure, or greater than 80% closure. An individual group should determine for themselves what clinical parameters make most sense for them. Personally, in our group, we report anything that is greater than 50% closure as a closed vein, but we do a follow-up scan approximately 1 month later to make sure that the vein has completely closed. If it is not completely closed at that 1 month mark, we then move that to a no closure outcome. Other complications of thermal ablation can include persistent swelling of the limb, blistering, allergic reactions to either the lidocaine, the tumescence, or any other solutions that are used during the procedure. Severe pain or phlebitis after thermal ablation should not occur, and if patients are requiring narcotics or require admission to the hospital, this needs to be logged as a complication. Infection is rare, but it, as well as numbness, seroma or hematoma, skin burns, and a failure to gain access or a failure to carry out the procedure should all be reported. All of these complications can be seen after ablation of the great, small, or anterior accessory veins. Phlebectomy is another common procedure to treat varicose vein disease. This can be performed in the office setting or in an operating room. Today I'll talk about the office setting, as most vein centers do not exist within a hospital. Office-based phlebectomy can range from a few incisions to many, and the scope of procedure has a lot of variability. For this, patients are usually anesthetized with both sedation and tumescence. Sedation may be intravenous sedation, or it may be oral only, according to the vein center's practice and their ability to monitor patients. When patients are sedated, they do need to be monitored, and the guidelines for this can be found in the IAC standards, and these usually correspond with the anesthetic guidelines of the individual states. Phlebectomy procedures are generally longer and more involved than endovenous ablation or sclerotherapy, and so proper precautions need to be taken to make sure patients are safe and comfortable throughout the entire procedure. When phlebectomies are performed, there is the potential for procedural bleeding, but this should be very rare. Tumescence decreases bleeding, and so liberal use of tumescence for phlebectomy is encouraged. Leg elevation helps decrease any bleeding during the procedure, and very extensive work may still need to be done in the OR where better lighting, suction, and resources are more available. Common complications after phlebectomy include hematoma, wound infection, retained veins, phlebitis, and occasionally deep vein thrombosis. Again, all of these complications should happen less than 5% of the time. Bruising and soreness are common, and in my personal opinion, unless these are extensive, they do not need to be logged as complications after this procedure. So now I'd like to come to our first polling question. During this question, I would like you all to answer for me, what is the most common complication that you all see after saphenous ablation? Some common ones that we see are, number 1, EHIT or DVT, number 2, hematoma formation, number 3, failure to close, or number 4, numbness and nerve injury. What we see is hematomas are our most common complication, followed by EHIT or DVT, numbness or nerve injury, and failure to close. All of these complications seem to be relatively of similar occurrence, and so it's good to know that approximately 10 years after thermal ablation has become commonplace, that these complications are of a low rate across the board. Next, I'd like to talk about logging of complications. All complications after ablations must be recorded, and this really requires a prospective log if you are doing it by hand in your vein center. If you're doing it through the EMR, in our experience, this requires specific coding to make sure that all complications are easy to search and are able to be found. To expect that someone will be able to pull the codes for ablation or sclerotherapy and then go back through the charts to find complications is, in my opinion, unrealistic. If doing it through the EMR, you need to set up your codes prospectively and hopefully have a drop-down menu where when patients are seen in follow-up, you can just check if a complication has occurred. I believe that this is the most thorough way of documenting complications. And again, you want to make sure that it's able to be searched so that when you run your quality reports, you can make sure you have accurate data. In our vein center, we've found that the most effective way to get this done is usually to have one person who takes ownership and runs the quality reports and then reports these results at quality assessment meetings. And this can be done really by anybody in the vein center with some clinical expertise who has an interest in quality and is committed to making sure that these logs are complete. It's really only by complete complication detailing that rare events, which should be any complication after venous procedures, or overall patterns in a practice can be discovered. I'd like to talk a minute now about non-thermal ablation. This is really a new frontier in saphenous ablation, and there are a variety of methods that can be used. I'll talk briefly about each one of these, because I know that these are penetrating to different extents across different areas of the country. The first method on the slide is the Venous product, and this is put out through Medtronic. Venous uses cyanoacrylate glue to deposit small amounts of glue, less than 1 cc, starting about 5 centimeters from the saphenofemoral junction, and you deposit the glue and compress the vein at measured intervals down the saphenous vein, and this glues the vein shut. There is no compression that is needed after this procedure. There's no tumescence, and there is really no pain involved in this procedure other than the cannulation site, which is numbed with lidocaine. The procedure takes between 10 and 20 minutes after you achieve some facility with the technology, and it is now available as a cash-only treatment. Varicose is a polydocanol microfoam that is a proprietary product of BTG. This also requires anesthesia only at the venous cannulation site. A catheter is inserted into the vein, and the microfoam is instilled until it reaches about 5 cm from the saphenofemoral junction where the vein is compressed. The foam is then allowed to sit and fill the vein and also reflux down distally into the leg as needed. And this, again, can be performed in about 10 to 20 minutes once the procedure details have been mastered by the treatment team. Sclerotherapy is produced by Vascular Insights, and it involves wire abrasion of the saphenous vein combined with a sclerosant, which is agitated during installation, and the combination between the abrasion and the sclerosant injures the vein and closes it down. No anesthesia is needed. Occasionally, a venous valve can be caught in the wire agitator, and this can produce a twinge of pain, but all that has to be done is the catheter slightly repositioned to carry on. Physician compounded foam is created all over the world every day, where air or CO2 is agitated with a sclerosant, usually polydocanol or STS. This is instilled under ultrasound guidance and can be used really for any vein in the body, but definitely the great saphenous
as well as other axial veins. This is performed more commonly in Europe than in the U.S., where they have less reimbursement for ablation techniques. I'll discuss all of these together as they all have similar complications, both to thermal ablation and to each other. So for the non-thermal ablation, no tumescence is used and no heat is used during the procedure. However, we do see many of the same complications as thermal ablation. DVT, phlebitis, hematoma, and failure to close are complications of all of these technologies. There is possibly a higher risk of systemic complications from sclerosants through the Claravane, Varithena, or physician-compounded foam technologies. These systemic complications include migraine and visual or other neurologic complaints. No burns or tumescence means, no heat or tumescence means no burns and no puncture sites, and perhaps a decreased incidence of infection or hematoma related to puncture sites from the tumescence. The same process for thermal ablation should be used for non-thermal ablation to log complications either through an EMR or through a hand-maintained log. I'm going to switch gears now and talk a little bit about sclerotherapy. Sclerotherapy can be performed with a variety of agents. The IAC requests that accredited vein centers use only FDA-approved sclerosants and use commercially available sclerosants rather than compounded products. Compounded products are allowed to be used if the vein center requires concentrations that are not commercially available. These can be used as a liquid or combined with air or CO2 to make a foam, and these can be used to treat axial to spider veins and everything in between. Sclerotherapy complications are rare but can be severe. Allergic reactions are one of the most common complications, and this can range from anything from hives to anaphylaxis, and for that reason, all vein centers need to have EpiPens available and a crash cart on the premises. Ulceration at the site of injection is a relatively common complication, and this may be more common with sodium tetradecyl sulfate versus polydocanol. We have also seen worsening of venous ulceration if extensive work is done. And again, neurologic symptoms such as migraine, visual changes, weakness, or syncope are fairly common. Some work has demonstrated that when foam is used, that neurologic complications are more common when room air rather than CO2 is used to agitate the sclerosant to produce the foam. Interestingly, neurologic complications are more common when surface veins are being injected rather than axial veins under ultrasound guidance. It is unclear if this is just because there are more surface veins injected with the foam, so it's a more common complication because it's a more common procedure, or if there is something about the injection of surface veins that makes neurologic symptoms more common. Because of safety concerns, many societal recommendations dictate that no more than 10 cc's of foam be used during any one injection event. Sclerotherapy-induced necrosis is a devastating complication, and this is a picture of one of our patients who was a CAP5 lady who had ultrasound-guided foam sclerotherapy using 1% polydocanol into a perforator near the site of a healed ulcer. This perforator met the SBS criteria for a pathologic perforator in that it was almost 6 millimeters, had reflux of more than 1 minute, and existed in the immediate vicinity to the healed ulcer. 8 cc's of polydocanol was used to fill the perforator, and this was milked out into an extensive network of surface varicosities. Unfortunately, this lady presented 3 days after the injection with what you can see is skin necrosis over the area of the healed ulcer. All of the surface veins that had been injected were thrombosed beneath this area, but unfortunately she went on to slough this area and needed ulcer care for approximately 4 months until this healed again. Based on experiences like these, we now suggest that less extensive work be done, that the perforator be injected at a separate sitting rather than extensive varicosities, and that perhaps a lower concentration of polydocanol be used rather than 1%. If retreatment is needed, that is definitely preferable to surface necrosis. As a vein center looks at their sclerotherapy complications, we also need to be vigilant for complications of administration. And this includes use of expired agents, contamination or expiration of pre-filled syringes, contamination of sclerosant when drawn up from multi-use vials, and the possibility of aspiration of glass particles if glass vials are used. Filter needles are suggested to combat this possibility. I would now like to go to poll question number 2. What do you all think the biggest barrier is to tracking complications in your vein center? Number 1, the volume of procedures is just too high. Number 2, there is no one there to do it. There's no staff redundancy. Number 3, you're not sure how to coordinate the logging of these complications with your electronic medical record. Or number 4, no one is really interested in tracking complications. Please vote and let us know what you all think. It's interesting. I think that at different times in running a vein center, all of these barriers have come up in one way or another. And sometimes it seems difficult to find the motivation to deal with all of these barriers. But as we're talking about, these are very important not only for accreditation, but I think for the safety of our patients. And they deserve to have their own complications tracked through a vein center so that the staff can be vigilant for problems that come up in their local vicinity. So as we look at the poll results, it seems that the electronic medical record presents the most problems for most people. And all I can do is suggest to work closely with your IT people. Unfortunately, since there are so many electronic medical records being used, it's hard in a national forum to really talk about solutions. But no matter where you are, your EMR can be customized for you. And I think it just requires a dedication not only from the IT team, but the people in the vein center to try to figure out what is the way that is most efficient and smoothest for them to work out tracking these complications. Now we're going to talk about how a vein center decreases complications and improves patient safety and outcomes. So as we've been talking about, tracking complications and reporting them can be hard. And doing this efficiently so that it is a new workflow and not an added effort is harder. Then using this information to change a patient experience and make procedures safer is most difficult. But this is why the IAC cares about it and why I know you all care about it. That's why you're tuning into this webinar, is because you're concerned about your patient's experience and safety, and you want to make things good for them and make your vein center successful. And so to track complications by hand versus the electronic medical record. This, I believe, depends on the volume of procedures that you're tracking and your own human resources. Small centers with smaller volumes with staff redundancy may be able to do this by hand. And again, a prospective log is really the only way to accurately track complications. This is usually initiated by the secretarial staff as they put a log together and may create forms that can then be maintained by any clinician. In our vein centers, we've found that APPs or nurses are excellent people to put in charge of tracking and collating this information and then reporting it back to the group. Larger volumes are very difficult to track by hand and almost mandate an electronic medical record. If complications can be coded to be searched, I believe that this is probably the most efficient and least time-consuming, but it does require a commitment by every practitioner to log every complication and to code it properly. Going back through medical records retrospectively is, I believe, not a sustainable way to accurately track complications. Tracking complications gets us to quality improvement. The IAC standards have given us a framework to assess and improve vein center quality. These start with the basic safety precautions. These include labeled drugs on the field when a procedure is being performed, the use of sterile technique, and basic suggestions and instruction can be found in the IAC standards, making sure that the patient has been properly identified and the marking of the treatment limb has been performed by the clinician who will be performing the procedure. As we go through the slides, you'll see there are annotations and citations of the different IAC vein center standard locations where these guidelines and sample forms can be located. So to have a quality improvement project, we need to look at outcomes data. Outcomes data for vein treatment is an emerging area, and the VQI has recently added a vein treatment module. Through use of this, venous benchmarks will be available in the not-so-distant future. Right now, there are no nationally recognized venous landmarks, and quality standards can be loosely taken from published work. The IAC is also working to establish benchmarking, and I'll talk about that in just a few minutes. When benchmarks are available, centers will need to compare their performance to national and local trends to see how they're doing to make sure that their patients are being treated in the safest way possible. There is a need to document venous clinical severity score, or VCSS, before and after each treatment. And this is part of the IAC standard now. And the reason for that is to make sure that the treatments that we are providing are actually improving patient well-being. This gets to indications. We all know that performance of ineffective or unneeded procedures are actually very common, and this should be viewed as a complication of venous treatment. I think the reasons for this are multifactorial. One is that many of our patients have a complexity of disease where they have leg pain and symptoms that could be from a variety of causes. Veins are sometimes treated, and the patients don't improve because their symptoms were caused by another entity. When we have very complex patients, this can make even effective venous treatment less satisfying for the patients, as their overall comorbidities keep them from being as active and healthy as they would like to be. There are practitioners who have been poorly trained at venous procedures and have little venous knowledge, and there it is even more challenging to make sure you're doing the right procedure the right way on the right patient. Occasionally, there are ethical issues involved in vein treatment or overtreatment, and so VCSS is a useful tool to try to make sure that the improvements we want to give to our patients are actually being realized. The IAC has mandated that when we are looking at indications, that a vein center needs to document indications for at least 5% of all of the cases performed, or a total of 30 cases, whichever is more. The total of 30 cases is to make sure that small vein centers report more than just a few cases. Appropriate indications for procedures are derived from societal guidelines. These are reviewed by the IAC staff as well as the IAC Board of Directors. Appropriate indications and positive outcomes must be assessed for this sample population to make sure that procedures are being performed for the right reasons and in the right manner. When the IAC looks at the indications data that is submitted, we look at the pattern of procedures that are performed and make sure that the procedures performed are appropriate for the numbers of patients being seen. We look at the rate of appropriate procedures and then set goals for improvement. When we look at measuring improvement, we look at indications data and outcomes data over time. Fulfillment of these steps will provide a center with a baseline of performance, and over time the IAC will use the data gathered from many centers to perform benchmarks. These benchmarks can then be given back to an individual center so that they know how they are performing in relation to other accredited vein treatment facilities. Quality of life determinants are suggested by the IAC to be used within a vein center. These are useful tools to determine the effectiveness of procedures, and there are many which are available. I would urge you to look at many different quality of life assessments, and we have listed a few here on the slide, including the CIVIC, the Vein SIM-Q, the Aberdeen Varicose Vein Score, and the SCORE-V measures, as they all have a slightly different twist or application, and some may be more appropriate to your patient population. If you see more medical varicose vein patients with a high ulcer population, this is a much different entity than a primarily cosmetic facility. And so you need to look at the quality of life scores that you believe are not only most appropriate for your patient population, but one that fits in with the workflow of your center. Again, I think it's very important to find a measure that you feel is sustainable, because if something requires an inordinate amount of extra work, the chance that it will become part of the daily workflow is very low. Use of quality of life measures allow a venous practitioner the chance to make sure that his or her treatments are improving patients' lives, and we all know that that's what we're all about. Right now, the IAC does not require a quality of life determinant, but this may become a requirement in the future. So, to wrap up this webinar is the review of complications slide. And this really incorporates everything we've talked about in the past 40 minutes. Each center has to have a policy to record and review all serious adverse events. A serious adverse event is any complication that is referred to an institution outside the vein center for management. And it's also any other event that the staff deems serious. I would encourage you to expand the reporting and the in-center discussion of all complications. And this, it goes down to allergic reactions and everything else that you document in your complication log. Complications are quite rare after venous treatment, and so it's important when any are documented that they be discussed. The IAC mandates the quality improvement meetings are performed at least yearly, and it's suggested that they be performed more often than that. I would encourage you to not only discuss complications, but also discuss indications, quality of life, patient satisfaction scores, and any other measures that you feel are important to the safety, health, efficacy, and happiness of your patient population. In these reviews, it's important to document policy changes that you feel are needed as a reflection of the complications that you have recorded. This then concludes the didactic portion, and I'd like to turn it over to Kelly and Marge for a question and answer session.
Thank you, Dr. Dillavou. At this time, we will begin the Q&A session, and we also ask that all of your questions be relevant to the information in today's webinar. Questions about accreditation should be directed to IAC by phone or email following the webinar. From IAC Vascular Testing and Vein Center, I'd like to introduce Marge Hutchison, IAC Director of Accreditation, who will assist with the Q&A session today. Marge, would you like to start us off?
Thank you, Kelly. Thank you, Dr. Dillavou. What an excellent presentation. And I would encourage people to either submit their questions online. If we do not get to them today, those questions will be answered throughout the next week via email, so you'll get your answer either way. The first question is, if a patient has a Class 3 or 4 EHIT, isn't waiting up to 14 days to scan too long? This particular person's practice standard is to scan within 72 hours of the procedure.
Marge, I think that's a great question. And what we have found in putting together the standards with 20 venous experts from around the country was that there was no one right answer. And the literature does not show us that 24 hours or 72 hours or 14 days is there's no one answer that has emerged as the magic time to do an ultrasound. I think you could make the argument that you should do an ultrasound 6 hours after a procedure, as most EHIT, we commonly believe, happens quite soon after the procedure is performed. What we have done is allow vein centers to use their own workflow and to use complication logs to document how this is working for their patients. If a vein center, for example, scanned people at 14 days and was having a fairly high rate of Class 3 or 4 EHIT or pulmonary embolism or hospitalization or deaths after ablation, then obviously these need to be addressed and the center needs to change their workflow and their policies. If, however, a center documents that they are checking people, that they are accurately logging complications, and they are having good results, we at the IAC Vein Center did not feel that it was our job to mandate that scans be performed at any one time. There's a small subset of venous experts that feel that because EHIT is so rare, that it really does not need to be done at all in the asymptomatic patient. But I think the common law standard of care is that an ultrasound be done to make sure that there is no EHIT that forms. And I know that most of the members of the IAC Board of Directors still perform an ultrasound for safety's sake, even though it is not reimbursed by insurance companies.
All right, thank you. The next question is, many patients experience numbness, especially after perforator or SSV ablation, sometimes persisting indefinitely. What are your thoughts about this? Well, it troubles me to hear many patients. I think that these should be very rare events. And if a center finds that many patients are experiencing numbness that persists, then I personally would stop performing those procedures because that should not occur. It probably reflects an inadequate tumescence around the vein. If these
if that is happening with small saphenous ablation, it may be because the vein is being cannulated too low, or where the vein is cannulated, there is inadequate tumescence to push the sural nerve away from the small saphenous vein. If you are experiencing numbness after perforator ablation, again, it probably reflects inadequate tumescence to isolate the perforator from the rest of the neurovascular bundle that inevitably accompanies it. And so I would be very vigilant about this complication, and if it was happening often, try to refine my technique or stop performing those operations.
Okay, thank you. Can Venocil and Varithena be used on very large diameter veins?
I would refer this question to the IFU for those products.
Okay. Have you ever encountered lymphedema as a post-procedural complication?
I personally have not, and it would make me suspicious that lymphedema perhaps existed prior to the procedure, and maybe the venous ablation was performed for leg swelling that was in fact due to lymphedema rather than venous swelling.
Okay. Why does the IAC require AED?
The IAC requires an AED to be on the premises in case a patient has an emergency and needs to be resuscitated. Although I know this is very uncommon in a vein center, it can happen. Personally, in a vein center where I used to work, we had a patient go into a full code from anaphylaxis during sclerotherapy. And I believe that having an AED on the premises has really become sort of the standard of care for any healthcare facility.
All right. Is nausea, feeling faint, vasovagal response considered a complication?
That's an interesting question, and I think it is. I don't really know if it's a complication, but it is something that I like to track, because if we find that many patients are experiencing this, then maybe we should we should look back at that and try to determine if there are common factors. Is it that people didn't eat breakfast in the morning and they're getting these procedures, on an empty stomach? Is it that they are being given a large volume of sclerosant? Is it that the rooms are too warm? Something like that, to try to determine if there are variations in our technique that can make this experience more pleasant for the patients. Also, too, by tracking these events, and I'm not sure they're complications, but they are events related to treatment, by tracking those, we can accurately tell people, in our experience, we find, 20% of patients become nauseated with injections. And, when you're performing a lifestyle modification treatment that's, nobody needs a vein injection to live another day, I really believe that patients need to know the possible complications and the rates of complications so they can decide if they want to proceed with these treatments.
Okay, thank you. Well, I think everyone is aware of Medicare pushing for whole leg treatments where as many veins as possible are taken care of in one sitting. What are your thoughts about this in view of lidocaine toxicity and other complications, in addition to maybe anatomy variations, FDA recommendations for single-use catheters, those kinds of things?
Well, that's a big question. That's a big question. Let me see if I can try to break this down. I think that we need to always keep patient safety and the individual patient in mind first. And it is great to be as efficient as possible in treating venous disease, but that should not come at the sacrifice of safety. So keeping lidocaine toxicity in mind and making sure that the catheters we use are appropriate for multiple uses within a single patient is very important because, you know, although the Medicare guidelines might suggest trying to do as much as possible, if an individual patient has a complication, that is due to the practitioner's judgment, not Medicare guidelines. And so, again, just treat the patient first and do what seems most appropriate for them. Marge, I'm sorry, I think I've forgotten the second part of that question. There's some part of it that I didn't answer.
Yeah, is there a point about where they should consider lidocaine toxicity? And then, of course, what about single-use catheters when they're treating multiple veins on the same patient?
I personally think that single-use catheters treating multiple veins is fine, as long as there is no indication from the generator that there is a malfunction with the catheter. Most generators have that feedback mechanism built in, and so if they're functioning well, I don't see a problem with that. And you do need to calculate a patient's lidocaine dose based on weight and make sure that that is tracked during the procedure so that toxicity doesn't occur.
Okay, let's change our thought process here a little bit. And what is the optimum duration of withholding Coumadin post-thermal ablation?
I don't withhold Coumadin at all, ever, for anybody. So I'm a bad person to ask. I just keep them on Coumadin. Even for phlebectomy, unless it's very extensive, I just keep them on Coumadin.
Okay. Someone would like you to reiterate a little bit more on closure rates.
Closure rates. Well, for thermal ablation, your closure rate should be 95% or more. That's full closure. For phlebectomy, they should, again, be in the high 90s. For sclerotherapy, like physician compounded foam, probably closure rates of anywhere from 60 to 70% are within the expected range. And with both Varithena and physician compounded foam, patients need to be counseled that they may need repeat treatments to get full closure. But the Varithena data has shown us that patients can have a therapeutic response without full ultrasound closure. And so that has sort of shifted the treatment paradigm for that technology, where you use Varithena, and if the patient's symptoms have improved, even if their vein isn't 100% closed, you then stop treatment, and then you retreat if symptoms recur. Rasmussen showed that a decrease in closure rates or an increase in recanalization over time was linked to increased symptoms after laser ablation. And so I believe that for thermal ablation, closure rates are still linked to symptoms, whereas with foam sclerotherapy or Varithena, it seems to be a little different. And you may get resolution of symptoms without full closure, and in that case, you should treat based on the patient's symptomatology rather than the ultrasound findings.
Okay, thank you. What about compounded agents? They're so much cheaper for the patients, but yet the IAC discourages that.
Right. This was a hotly debated topic when we were writing to the standards. And the reason that we decided to go with only commercially available products rather than compounded products was that there have been several highly publicized incidences of contamination associated with compounded pharmacies, plus the purity of the agents is markedly decreased with compounded drugs versus commercial drugs. The IAC board members felt that it was a patient safety issue, and so we mandate that commercial agents be used whenever possible.
Okay, and I got one last question that's going to change things a little bit. What is your thought on ablating superficial veins when deep reflux is present?
Oh, that's a good question. That's an interesting one that we didn't talk about. I believe that can be therapeutic. And again, the patient should be counseled that they are unlikely to have a full resolution of symptoms. But if they have large refluxing surface veins in combination with deep reflux, I definitely will ablate the refluxing surface veins and let them know that they are still likely to have some degree of discomfort or swelling or whatever their symptomatology is, but that it should be improved. And this may allow them to have some stocking holidays. It may take their symptoms from severe to moderate, and I believe that it's a favor for the patient.
All right. Well, thank you so much. I'm going to let Kelly come back on and close us out here.
Thanks again, everyone, and a very special thank you to our presenter, Dr. Ellen Dillavou. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars. Look for the title of this session, Complications and Adverse Events in Varicose Vein Treatment. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intrasocietal.org. Once again, we thank you all for joining us today and appreciate your participation.